droopiness of the eyelid muscles, lifting up her eyelids using her forehead muscles. The squint shown by this sort of inward deviation of that eye. That lady unfortunately can't move her eyes very much at all. So that's external ophthalmoplegia. There are a number of, because time's going, I'm going to skip a little bit faster. There are a number of clusters of these sort of symptoms and signs, if you like, which have led us to understand these diseases in terms of what we call syndromes, which are patterns of disorder affecting various organs and tissues. There are many. Remember that slide that I showed you of all those little mutations in the mitochondrial genome? Many of those were individual syndromes. So it's difficult to talk about all of them, but there's some very, shall we say, common patterns. And one is something called MELAS, which is a pattern of abnormality. There's another one which is called MRF. These are all acronyms where the letters stand for the kind of main problems that the patient suffers. There's no point actually necessarily remembering all of this. And there's something which has got an eponymous name, meaning two individuals have joined their names and given their name to the disease, called the Kearns-Sayre syndrome. But there are many others, some with eponymous names, like Lee syndrome, Leber's optic atrophy, which is an eye disease. And then commonly in the clinic now, increasingly we're realizing a nuclear encoded problem called polymerase gamma, which is an enzyme that is important for the copying of mitochondrial DNA. So that can lead to a problem with not enough mitochondrial DNA or fractured mitochondrial DNA, which leads to a recognizable syndrome. So I'm going to skip very quickly over these because of time. David is going to talk about diagnosis, so I'm just going to say that this is a very rapidly changing field. In the history of these diseases, back in the 1970s, these diseases were really recognized in a bunch of children who had all kinds of disorders of muscle, brain, vision, and hearing. And the first thing that came out of that is that in the examination of their muscle, abnormalities of the mitochondria could be seen. And this is a particular stain that shows that in some of the muscle fibers, each of these blue things is a muscle fiber, that there were these abnormal clumps of red material in a certain kind of stain, and this stain actually stains mitochondria. Very similar to the stain that I showed you in living cells right at the front of the talk. And these were clumped, they were abnormal, that when you looked under the electron microscope, the mitochondria itself didn't look like the kind of thing that I showed you. But there were abnormal chambers, if you like, within this double-walled chamber, and there was all kinds of gunk inside it. And then when you looked at stains that actually measured the respiratory chain in these muscles, there was patchy deficiency in the muscle. So it used to be that this was kind of the way we set about trying to diagnose these diseases, by doing muscle biopsy. But as it's turned out, this sort of abnormality is typically seen only in certain types of mitochondrial disease, particularly those of some of those point mutations in the mitochondrial DNA, not all of them. So largely with the advent of more sophisticated genetics, we've been able to go straight to the genes causing these diseases in order to make a diagnosis. So the genes are tested in the mitochondrial DNA, but also in the nuclear DNA, and this is the focus of much of David's work, is about searching for new genes in the nuclear genome that cause these diseases. One of the complexities that I didn't talk about a little bit earlier is that mitochondrial DNA is not, or abnormalities in mitochondrial DNA are not always equally found in all tissues. So when we're looking for a mitochondrial DNA single gene mutation, we're often looking in certain tissues. So if you like, the study of these diseases does depend on which tissue you study. Increasingly, I think we're going to be able to do most of this on DNA that is extracted either from blood or from the urine. Now, this is a very complex slide, but I'm going to finish very soon. So rather than try to understand all the details of this slide, I just want to take you through it in the clinic about how we approach this right now. And as I said, this is a changing landscape. But in the clinic, we're still pretty much stuck with some kinds of fairly slow-moving, sometimes time-consuming, nearly always time-consuming methods of achieving a very precise molecular or genetic diagnosis. And that's because although the tools of genetics are there, they are not really readily available to everybody, and certainly not at a low cost, or even an affordable cost for many people, although this itself is very rapidly changing. So in the clinic, confronted with a person who might have one of those syndromes, we try to see if we can recognize something, some of those patterns, and that's good old-fashioned clinical medicine. Spend most of our time doing, recognizing patterns. Once one's seen thousands and thousands and thousands of patients and has the idea of what sort of problem they may have, including this one, which is a sort of an uncommon type of problem that one's presented with in the clinic. One can suspect a syndrome, and there is some kind of inheritance pattern in the family that leads to a clue that we should be studying the mitochondrial DNA. We can do that. That's in the yellow box here. We can do that reasonably easily, and we have been able to do that for decades now by analyzing the mitochondrial DNA for little errors in it or chunks missing, and that sometimes requires different kinds of laboratory testing. Sometimes we can recognize that this syndrome might be, according to the genetic inheritance pattern or the nature of the syndrome, especially in infants and children, might in fact be a nuclear inherited defect. So if we can recognize something, then on blood we might be able to, in the blue box here, identify some genetic nuclear gene disorder. And as I said, this has been the old style of us working, where much of it depended on recognition and then trying to, for cost reasons and complexity reasons, channeling our investigative pathways into one of these boxes. But it's, if you like, a sort of it's just a candidate genes. I mean, we're just suspecting something and then we're looking for it. We're not really looking for all possibilities that can cause that. And that's just guided by the clinical experience of the people who are seeing the patients. Another avenue, even more expensive still and more complex, is to actually study the biochemistry of mitochondria in tissues taken from the patient. For example, a muscle biopsy or fibroblasts. Increasingly, as genetics has been available, these yellow and these blue boxes, we're doing less of this, but sometimes that is still necessary, where we suspect that the person might have a mitochondrial disease affecting the function of the respiratory chain, and that can be studied in a laboratory such as David's laboratory in muscle. So that's our approach. If we're able to find a mutation, we can extend the genetic studies to family members to then counsel them about the nature of the inheritance pattern in their family. And it gets back to that kind of complexity that I had right at the start. And sometimes, in fact, quite a lot of the time, we suspect that the patient has a mitochondrial disease. We have many patients like this. We don't find a mutation, but we know they've got a mitochondrial disease because of various clinical and other factors. This is not the only method. Increasingly, we are using imaging, although not specific, but at least gives us a clue It's part of the clinical assessment. For example, here's an abnormal MRI for a particular kind of stroke that we see, which is nothing like other strokes in a person suffering MELAS. And MRI itself can be used through magnetic resonance spectroscopy, a clever MRI technique to study ATP generation within the brain, and then we can use MRS to look at parts of the brain to know whether there is a dysfunction of the mitochondrial respiratory chain. Now, I'm going to stop here because I know that David's going to talk a little bit about treatment. My time's, I've gone well over my time, I'm sure. I'm going to simply say that the overall clinical assessment of the patient first relies on diagnosis, assessment of how it affects them, and largely today it's symptomatic treatment. That's all we have to offer patients, apart from optimization of their function, which is about healthy living in general and about lifestyle factors. Most of this can be achieved if the person attends a clinic where people deal with these disorders. We have such a clinic for adult mitochondrial diseases at Monash, which is something that I run with a colleague, the pediatric neurologist, Dr. Fay. And there is a similar clinic for children at the Children's here. I'll skip over these slides very quickly because they're a bit detailed, but suffice to say that we've got particular approaches, some of them biochemical and some of them pharmaceutical, to treat some of the complications of mitochondrial diseases, such as strokes that may occur, the treatment of epilepsy, which is it is largely similar to the treatment of ordinary epilepsy, although there's some caveats because some of these medications that we use for epilepsy can worsen mitochondrial diseases and not make them better. So there's judicious use of anti-epileptic treatment, and then there's a variety of pharmaceuticals that we use with various cocktails of vitamins that improve the efficiency of the mitochondrial respiratory chain. And this is not just in the acute setting, the patient in the hospital will run these rather sometimes catastrophic complications, but also for most people who have mitochondrial diseases who are just living their lives without any catastrophic complications, to try to keep them optimized in their function.